Hello, everyone, and welcome to the next in our series of Earthenars. We are super excited today to have an excellent speaker who I'll be introducing in a minute. But before that, I want to remind everyone that our annual Research and Translation Forum is coming right up in February. It's 11 a.m. to 5 p.m. in Mission Bay Conference Center. All right. So we're super excited to have Helena Archer, who is a postdoc in the Department of Environmental Policy, Science, and Management. She received her PhD in epidemiology at UC Berkeley, and she focuses on environmental and structural drivers of infectious disease. So her current research evaluates COVID-19 outcomes among environmentally vulnerable populations, including state prison populations and California residents with exposure to pollutants and related hazards. And she's going to be talking about her paper on upstream oil and gas production and community COVID-19 cases and mortality rates in California. So we're super excited to have you. And also thanks to her mentor, Rachel Morello-Frosch, who is also another Earth member. And I will turn it over to you. Thank you so much for presenting. Oh, and please feel free to put your questions in the chat as Dr. Archer moves along.
Perfect. And then I also just take the moment while Helena, Dr. Archer is sharing her slides, is that she and Dr. Frosch, Morello Frosch, were the recipients of one of our Earth Seedling Awards.
Oh, yes.
So these are little funding mechanisms we have that are exclusively for Earth Center core services. And so they use the biostatistical support from our Translational Research Support Corps, formerly known as our IHSFC, and Peggy Reynolds and Aaron D'Amico are the directors of that core. So within that realm of support, we also have study design, wildfire consultation. There's a whole array of mechanisms that we can help support. So you can take a look, and I'll drop a bunch of links in the chat
for your excellent environmental
projects.
Research. Yes, thanks. Thank you, Alana.
Yeah, well, thank you very much. Again, we're very, very grateful to have the statistical support from John and from the center. And thank you for the invitation to speak today. And thanks, Rachel, as always, for joining. And I saw that Peggy and Julie are also on the call. So it's great to see you, and who are, of course, a big part of this paper. So thank you, and Gina as well. Yeah, so without further ado, yeah, so I thought, I think some of you might have heard me present on some preliminary results on this paper, maybe almost a couple of years ago at this point. When we first started working on it, I'm delighted to say that the oil and gas paper was published in November, so we do have final results on that. And then I had the opportunity to continue working with Rachel at the UC Berkeley Superfund Center and do some work building off that oil and gas paper using the same outcome data set to also look at some water contamination outcomes. So I'm going to talk a little bit about that subsequent study as well today. So as Alana said, please feel free to interrupt if you have any, or just like raise your hand or put it in the chat or whatever. I'll pause if you have any questions, but I'm just going to sort of talk about one and then the other. And as always, I invite the many lovely people who are mentoring me on these projects to jump in as well. So the first one, as I mentioned, is upstream oil and gas production and community COVID-19 rates in California. So again, big thank you to all the co-authors, as well as Gina, Peggy, Gina, Julie, and our center for their support. This is in the journal GeoHealth now. So I'm just trying to keep my video on the side, but a little bit smaller. 1 second. Yes, I'll talk about some of the results of the study. So a little bit of background. I saw there's something in the chat. Oh yeah, thank you. Oops. A little bit of background. So this study, which was part of my dissertation, was developed as a companion analysis to a UCSF and Track in California air quality study that was looking at COVID-19 outcomes and PM2.5 in California that got started pretty early on into the pandemic. I think began even as early as 2020 or 2021. And I mentioned that because the focus of all these projects is really looking at some of the earlier first year of the pandemic data. So if you can sort of pull your mind back to what was going on back then, if it's not too upsetting to do so, and thinking about, what we saw with environmental drivers of disease, sort of at the onset, or really thinking at the beginning of the pandemic. And most of this data is pretty much from before vaccines became available. So although I'm actually going to be starting to do some work on vaccines in a new position soon, this is going to be all sort of pre-vaccination COVID-19 data. So the objective of this study was to examine how area level exposure to oil and gas production related pollution measured through residential proximity to producing and active wells may have affected COVID-19 outcomes. I was really delighted that this project was also connected to policy and advocacy from the Center for Race, Poverty, and the Environment, the California Environmental Justice Alliance, as well as all of our academic partners who also work hard on policy as well. So as a reminder, between December 2021 and May 2022, sorry, it should be December, anyway, should be December 2019, sorry. There were 82 million recorded cases and 1 million recorded deaths from COVID-19 in the US. Knowledge of environmental drivers of disease can be critical for pandemic preparedness when thinking about communities that may be vulnerable to disease, especially when knowledge of response and prevention measures are limited. As you recall, there was significant interest in air pollution and COVID-19 across researchers at the beginning of the pandemic, and there were many, many studies released to this effect. In a 2022 systematic review, the authors found that about 50% of the studies reported a positive relationship between air pollution and COVID-19 and incidence, so looking at cases, and about 48% reported a positive relationship between air pollution and COVID-19 mortality. So definitely an area where there's a lot of research, but there's a lot of room to grow in sort of our understanding of how these two things are related for COVID and for other respiratory diseases. So for our study, we focused on oil and gas drilling. Globally, over 600 million people are estimated to live near active oil and gas development, including an estimated 17 million people living within a mile of an active well in the United States, as of a 2017 study. So oil and gas drilling may emit multiple pollutants, including the air pollutants NO2 and PM2.5, in addition to other air, noise, soil, light pollutants, and other stressors. Some research has linked residential proximity to active drilling with several adverse respiratory outcomes, including asthma, cancers, immunodeficiency, and heart failure, in addition to a lot of other research done at Rachel's group looking at perinatal and pregnancy outcomes, which is a very active area of research as well, if that is an area that you're interested in. It's been linked to environmental justice research, which also has important implications for COVID-19, with new evidence around redlining and disproportionate exposure for communities of color, including communities of color in California. These are just a couple pictures of that. So as I get into the text on this slide, I just want to mention something that came up as we were writing our paper, and particularly something that came up in our review process. So for the purpose of this study, we are very focused on the total exposure to area level oil and gas production. As I mentioned, there can be a lot of stressors associated with this. So as an exposure that still would be considered underrepresented in the research, it's not as well understood as maybe other types of specific types of air pollution. We were focused on people exposed to the whole sum of activities rather than elucidating specific mechanisms, particularly because we have area level measures. So in California, you've got an estimated 2 million residents living within 1 kilometer of an active well. So to try and estimate which proportion of the California population for our study was close by a well, we used what's known as sort of asymmetric exposure assessment, or looking within block groups, which if you're familiar with block groups, which I imagine environmental health people mostly are an administrative sort of spatial unit with about 600 to 3,000 people generally. And there's about 23,000 of them in California. So within that, we took advantage of some work other researchers have done to try and find where populated areas were, so that as we look within this administrative unit, we focus on wells that we know are close to people that are close to actual where people are versus rural areas where there's no one around. So as you can see in the example on the left, we did, for our measurement and thinking who was exposed to which wells, we looked sort of within these sub-block groups to try and identify areas where people were exposed. So for example, in that top block group, even though there is a well there, it's not near any of the areas where people are, so we wouldn't consider the population in that group exposed. So within these, after sort of identifying where wells and where people were close by, we created 10 kilometer, 3 kilometer, and 1 kilometer buffers. So thinking of our very close, a little bit further, and then quite a bit further away for our active 2018 to 2020 wells. And we limited our population to block groups that were within 10 kilometers of an active well. So only the block groups that were we consider somewhat close to a well. And I'll show an example of how we did that on the next, or what that looks like on the next slide. But I just want to say the reason that we did that was to try and identify, for epidemiological purposes, a population that we thought was a bit more similar for comparisons that had this different exposure of the active wells but that was relatively close to a well, because as we know, wells aren't distributed randomly. We believe that people living somewhat closer to a well are more similar to each other. So that was an attempt to help us reduce some types of confounding, to go people with this common exposure of being near a well, but different actual proximity to the well and different presumed levels of exposure within that group of people. So what that looked like in the results of the study were these 3 layers that we see here. So the little gray dots are our wells. I've shown the 1 kilometer buffer, so that's the little yellow line around there. And you can see that the ones in red are what we consider our exposed groups. So those are block groups that are very close to a well within 1 kilometer. And then we identified our unexposed groups, or people that we thought were still close to a well, but far enough away that we thought they're going to be different than the people that are very close. And we said that would be if you live between 3 and 10 kilometers away. So that's our main comparison group. And then you have this sort of washout area in the middle where people are more than 1 kilometer, but less than 3 kilometers away. And we said they're a little bit in between. So we're going to keep them in for comparison, for thinking about confounding, but really we want to focus on the differences between the people we have good reason to think are exposed, and good reason to think are, if not unexposed, like much less exposed, because they're quite a bit further away from the wells. So for us, that took us down from the 23,000 block groups to about 8,500 block groups in California. So about a quarter of the block groups in California were included in the study. About 1,100 of those were exposed, 5,000 unexposed, and then another 2,300 in our intermediate group. And within this, we linked 1.3 million cases and 2,400 deaths from COVID-19 from this about 3 million cases that we received from the state that we could link geographically. Excuse me. So for our exposed groups only, so just the 0 to 1 kilometers, we estimated exposure to barrels of oil equivalent. So that's BOE, and that's about our active production, or how much wells were active and how much they were producing from nearby wells. As you can see in this chart here, and this is sort of a cross section of incidents and our wells. If you look on the bottom, we've got quite a range of a lot of people being exposed to some production, but not tons of production, and then some places with really high levels of production, or as you saw in that picture, some really high clustering of active wells. So this is one of the areas where we used the seedling grant, was to take advantage of sort of prior studies of oil and gas production, where you also see these real ranges of, and sometimes very skewed levels of exposure, to think about how to work with the data to best think about these kind of measures. So where we landed was splitting our well exposure group into tertiles. So the people that were, equally sized groups, but with a different range. So in our lowest tertile, people that are exposed, but at our lower levels, our middle tertile exposed, but in the middle group, and our highest tertile. And to analyze this, I won't talk too much about the detail, but we ended up using hierarchical Poisson models to help us think about both sort of spatial clustering of people within census block groups, and then within larger geographic areas, both for sort of well overlap, and then also where we know COVID-19 cases were distributed. So we used hierarchical Poisson models with 2-level random intercepts for the block groups and for the census tracts. Another thing that we talked with John about was thinking about what else to include in this model. So I wanted to look at COVID-19 cases over time, again, within this first year of the pandemic. And this is split up by age category and by sexes registered within the case. And we just had sort of female and male information here. We didn't have further descriptive data than that we were able to include here. And if you can see, oops, there you go. We see sort of a trend of 3 areas as we wanted to think about some time trends happening in the back. So we ended up grouping them based on sort of an earlier time period, really at the beginning, when there was fewer testing, fewer identified cases. The middle area where you had somewhat of a summer surge, that's maybe between like May and August. And then I'm sure I have to think about it to remember exactly what happened about 4 years ago. But at the end, this is when we saw really the first sort of surge of cases and more widespread testing in the first winter of the COVID-19 pandemic. So to think about within this first year, what were some of the errors happening, and we ended up including this in our models as well. So just to recap, this was an ecological cohort study, so looking at area level measures of our exposure and area level outcomes, so the number of cases over the total population in the area. And again, that's within census block groups. We thought about how we would assign our oil and gas production to area and the changing policy, knowledge, and patterns of COVID-19 over the study unit. We included individual age and sex in our covariates, as that was something we were able to get from the case data, area rurality, racial and ethnic demographics for the areas, and socioeconomic indicators. We did include a sensitivity analysis of comorbidities. I won't include that here because it didn't really change our results, but it was something we considered. And then just again, we used these Poisson models. So looking at some of our results, if I can bring your attention first to the left piece here. Again, I mentioned we've got these 3 different tertiles in our intermediate group. So you can see for our estimated barrel of oil equivalent in our low groups, you have, and this is based on sort of average, per wells, and this is average annual amount. In our low group, you've got sort of less than 1 to about 3,000. In our middle group, around 3,000 to 27,000. And in our highest tertile, again, that range gets pretty big. So around 28,000 to 3 million. So that's something that we weren't really able to further investigate in the study due to some of our limitations, just, being this was an area level study, but something I did want to mention that this is some of these places really have, quite high exposure. So over our entire time period, you can see and adjusted here, we saw more or less a null effect across the groups. All the rates were pretty close to 1, and all sort of crossed the threshold, including our intermediate group. But then when we broke out our results by time, we did actually see some evidence of a relationship in this first time, or some evidence of an association in this first time period, where we saw higher rates pretty much across all levels in our groups, and the highest level in our highest tertile groups are again our people with significantly higher levels of exposure, and particularly higher than the other groups that we measured. When we looked at deaths, we saw something that was fairly similar. So again, in our adjusted group, we saw mostly null results, with the exception again of this highest tertile group, or even across the entire time period, we did see an association. So higher rates of reported mortality in our plot groups where we know there was higher, or where we know there was higher reported exposure to active oil and gas production in 2018 through 2020. This was somewhat similar over the thing where we had somewhat similar over the different time periods, where we saw a stronger association in this first time period, and then it tended to attenuate in the later time periods. And that was true across pretty much all our levels. I'll note it was a bit different in this middle tertile. And I'll just mention that I didn't put the results in here, but we did try breaking this out into more groups. So we did 3 here, but we looked at 4, we looked at 5 to sort of push this out a little bit further. And the trends are very similar. Even with additional categories where, it's higher in the lower ones and higher in the highest ones, sort of no matter, even if you made that group a bit smaller, the highest one stayed. And this sort of bell curve here stayed a bit. So something for us to think about for future research. I'll just mention like I said, we're not able to investigate everything here, but we did try to look at some additional things as well, including with stratification and things other than times. This is over the whole time period, but broken out within our age group, since we were fortunate to have age data at both our cases and in our denominators. So you can see, for example, if you look at far left, this 0 to 19, you've got a bit of a range between our low, medium, high, intermediate groups. They vary a little bit, but they're all sort of crossing the null around the same here, with a little bit of a lower exposure in the high group. But I'll mention these 2 on the right side. And this is, again, sort of an exploratory analysis that we wanted to include, that we did see that it appeared that the driving relationship for some of our higher rates in the highest group were among these older age groups, where we saw these higher rates in both incidence and mortality in the 65 plus, among 65 plus residents of California, as measured at the area level. So this is something that, we would think would be potentially valuable again for future investigation. So some of the thoughts and limitations, we thought the results of the time stratification may be important for assessing vulnerability for future respiratory outbreaks, because we know that in the first time period, there were lower rates of testing and people were more likely to be tested if they were symptomatic or severe. And because we saw a stronger association with deaths, that if there is a true relationship between, or if there is a driving association between oil and gas production and COVID-19, it might be on severity, as severe cases would be more likely to get detected earlier on versus later on, when it might be, more people were able to get tested. So that effect might even out a bit. Although, again, we saw some differences for mortality. But that was, that was one of our hypotheses for why we might be seeing this. We did note that there was a persistence of the relationships, even given adjustment for a number of potential confounders that people have raised in the literature, sort of, including demographics, socioeconomic demographics, particularly given that we had measures related to healthcare access. We noted high variability across local areas when we looked at some statistics with our sort of between area differences. There's a lot of variability in the underlying data. And we hope this adds to a growing body of evidence around health impacts related to oil and gas wells and COVID-19. Just some notes on the limitations. Again, this is an ecological study. We're not able to directly assess individual risks. We did have limited data. Unfortunately, there's just not, or there wasn't at the time we did the study, data on differences in policy and testing across the study period. So, differences in, rates of testing where that was happening, we're not able to directly measure that. And just noting that this can be a complex relationship. Again, we wanted to focus on the total effect, which helps us then think about mechanisms, but there are a lot of challenges to estimating it, and that it can be a statistically complex thing to estimate as well. So I'll pause here on this first study. I wanted to say additional thank yous again to Julie, Gina, CRPE, and the Earth Center, of course, supported by this award as well.